Hello everyone, my name is Kelli and this is my quality improvement project. This presentation focuses on quality improvement in the clinical setting through the use of an evidence-based intervention. And in this case, the proposed intervention that I will be discussing is palliative care education and implementation for nursing staff in the acute care setting. So as I just mentioned, this quality improvement project focuses on nurse-led palliative care, but it is first important to discuss why this type of project is needed and what our problem is. First, quality improvement is essential to provide safe, high quality, and responsive services for patients. This leads to improved patient outcomes, reduced costs, and increased satisfaction overall. It is also important to incorporate quality improvement into our practice to encourage education advancement and to strive for efficiency. Next, the problem identified in the project is that there is a gap in understanding how the involvement of nursing staff trained in palliative care compares to nursing care without palliative care training, and how it affects the quality of life and symptom management in acute care patients during their hospital admission. By implementing the quality improvement project, we hope to solve our problem while also enhancing patient care and improving outcomes. Some evidence to support the need for this project involves the increasing number of patients with complex health conditions that require comprehensive support and specialized care. With increasing rates of terminal illnesses and hospital admissions, there is a need for enhanced healthcare delivery and palliative care utilization to optimize patient outcomes further. As a nurse, I can reflect on my 6 years of patient care experience, and I feel like patient acuity has definitely increased. With this increase, it places even more emphasis on the need for quality improvement to meet the demand of the higher level of care. Without proper research and evidence to identify a correlation between nurse-educated and led palliative care, there is potential for practice binds in patients' clinical and psychological management. In other words, to best serve patients, it is necessary to investigate the ways in which we can improve and adjust our care to best meet their needs. To further support the need for this project, we know that registered nurses represent the largest healthcare workforce and are present for the majority of care for patients. Due to this, it is important to investigate if registered nurses are ideal candidates to provide primary palliative care to patients with chronic conditions. The intervention implemented to address the problem discussed involves a curriculum aimed at educating nurses on the benefits of palliative care goals, and how to implement these processes into patient care. To educate nursing staff, the curriculum will focus on several factors, and these include symptom assessment and management, emotional support, advanced care planning, and care coordination. Symptom assessment is used to better understand a patient's symptoms, including their severity and how they will impact quality of life. This will allow nurses to personalize their care, focusing on patient-specific needs. Emotional support in the curriculum focuses on providing empathy and encouraging patients to help them cope with the emotional changes of their illness. By providing advanced care planning, this will allow patients to make informed decisions about their health care and will ensure that their preferences and wishes are understood and respected. Last but not least, care coordination is utilized to make sure patient care activities are organized and that all participants are involved in their care. This curriculum for nursing staff provides a framework for palliative care and will further help us evaluate the effectiveness of nurse-led care. A checklist with key goals will be followed to further individualize care to improve patient outcomes. These goals are specific to each patient, but relate to improving their quality of life and decreasing the burden of their symptoms. The factors of this intervention are to be implemented during hospital admission for acute care patients. So up next, we will need some evidence to support the effectiveness of our intervention, and we have a few studies and outcomes noted here. Each of these studies implemented an intervention with very similar factors, all including nurses who are specifically trained to deliver palliative care to patients with terminal illnesses. So up first, one study found that compared to patients receiving standard care, participants receiving the nurse-led palliative care intervention had a higher quality of life, decreased depressed mood, and decreased symptom intensity. All of these outcomes are highlighted in our intervention curriculum and are the basis for why we implement quality improvement into practice. The next study found that a statistically significant number of end-of-life care patients in the intervention group received increased care on the oncology unit. This care included improved anxiety and agitation management through the use of comfort medications, therefore improving quality of life and decreasing symptoms. Lastly, an intensity-adjusted analysis determined that a full dose of a nurse-led intervention resulted in significantly improved mood symptoms and quality of life. Here we can see that we have pretty substantial evidence that our intervention will be effective, will help us solve our problem, and can lead to the formation of quality improvement in the clinical setting. So in order to implement our intervention, we will be using the Institute for Healthcare Improvement, or IHI. We'll use their model for improvement. This model is shown in the picture on this slide and is a very useful and powerful framework for generating improvements and changes. This model has two parts, the first being 3 fundamental questions. So those are, what are we trying to accomplish? How will we know that a change is an improvement? And what change can we make that will result in an improvement? So we'll start by answering the first 2 of these questions. The first being, what is it that we want to accomplish? Ultimately, our goal through this project is to enhance patient care and to improve their outcomes through the implementation of nurse-led palliative care. And how will we know that this change is an improvement? This will focus on the outcomes that we are measuring, and those are reported quality of life and symptom management. To help us further answer this, we will utilize a SMART goal. Our SMART goal is 75% of terminally ill patients in the acute care setting will demonstrate improvements in their quality of life and symptom management during their hospital admission through the implementation of nurse-educated and led palliative care. And our next slide will lead us into implementing the next portion of the IHI model, and that is the cycle of plan, do, study, and act. All right, so first up in the model is the plan. The main idea for this portion of the model is to answer the who, what, where, and when of our quality improvement project, which is implementing nurse-led palliative care. Our setting will take place on an inpatient acute care unit. Our population of interest includes terminally ill patients during their hospital admission, as they are the population of patients who are shown to benefit greatly from palliative care. This may include patients with advanced irreversible disease, limited life expectancy, or those with a progressive decline in their health. And the team members who will be involved in the project, of course, focus on nurses, the ones that are delivering the individualized palliative care, but we can't forget about how important a multidisciplinary team is for patients. These benefits include enhanced communication, improved patient outcomes, and personalized care. So even though our focus with the project is aimed mostly at nursing care, the outcomes of our patients will still rely on the collaboration from a full team, including physicians, therapists, social workers, pharmacists, dietitians, and many more. Up next, we have the do section of the IHI model. This is where we carry out and implement our plan and our intervention. To begin this process, nurses on an inpatient acute care unit will complete an online 2-hour education tool, and that provides a thorough background on palliative care and focuses on the factors that were previously discussed. So those are symptom assessment and management, emotional support, advanced care planning, and care coordination. These are the key factors that will drive individualized palliative care. And this online education tool features a testing portion at the end to ensure that learning goals were met and that the RN is prepared to provide this type of care. A score of 90% will be required to pass. Next, a care plan is created for each patient and is updated in real time by nursing staff as goals are met and items are completed. This checklist features an outline of each of the key factors discussed. Nursing staff is to address these items every shift and document them accordingly. In order to track patient outcomes, and in this case, their quality of life and symptom management, assessment tools will be utilized. One of the studies discussed from the evidence section utilized a scale called the Functional Assessment of Chronic Illness Therapy, Palliative Care, or FACIT-PAL. This tool identifies quality of life concerns for patients with life-limiting illnesses and has shown responsiveness to change. The scores range from 0 to 184, with higher scores indicating better quality of life. And the tool used to assess symptom management is the Edmonton Symptom Assessment Scale, or ESAS. This is a 9-item patient-rated instrument that was developed and validated for patients with cancer and other terminal illnesses, and the scores range from 0 to 10 for each item, for a potential total score ranging from 0 to 90. Items such as pain, tiredness, nausea, anxiety, depression, and several others are rated. A higher total score indicates greater symptom burden. Patients will complete both of these tools at the time of hospital admission to create a baseline score, and will complete them once every other day until the time of discharge or until the patient unfortunately passes away. Our next step in the IHI model is study, or where we collect, evaluate, and analyze the data. We have some process measures and outcome measures to collect and evaluate here. And first, we will start with the process measures, which are the nurse education tool and the patient palliative care plan tool. These process measures are in place to verify adherence to the implementation plan. As I mentioned before, nursing staff participating in the quality improvement project must complete a 2-hour education tool on palliative care and score a 90% to pass. In order to evaluate these scores and to gauge the preparedness of the staff, descriptive statistics will be used in the form of mean and standard deviation. Standard deviation will tell us how spread out the scores are from the mean, with a larger value meaning greater variability. The next process measure, the palliative care plan tool, is measured by the number of times it was completed by RN staff compared to the number of days the patient remained in the hospital. So if a patient was admitted for 10 days, but the nurse only completed the care plan tool 8 of those 10 days, the score would be 80%. We can also use descriptive statistics, the mean and standard deviation, to evaluate these outcomes. Up next, we will look at our outcome measure, which evaluates the impact of the intervention on the population. The FACIT-PAL and ESAS scores that were discussed previously will be used for outcome measures. To recap, patients will complete both of these tools at the time of hospital admission to create a baseline score, and will complete once every other day until time of discharge or until the patient unfortunately passes away. To examine the impact that our intervention had on these quality of life and symptom burden scores, inferential statistics will be used in the form of a t-test to determine if there is a statistically significant difference between the measurements taken before and after the intervention. All right, and last, we have the ACT portion of the model. This is where we reflect on the project and determine what we will change and what we will keep the same to implement the next cycle. So first, let's take another look at our SMART goal and figure out the minimum amount of change in the outcome measure that is needed to see improvement in our population. And a reminder, the SMART goal was that 75% of terminally ill patients in the acute care setting will demonstrate improvements in their quality of life and symptom management during their hospital admission through the implementation of nurse-educated and led palliative care. So in order to see the goal improvement in our population, 75% of patients will have to demonstrate at least a 15% overall improvement in their patient screening tools, or in this case, the FACIT-PAL score and the ESAS score. These are the tools that measure quality of life and symptom burden again. For example, if a patient scores an 80 on their ESAS test at the time of admission to the unit, they would need to score at least a 68 by the time of discharge to demonstrate a 15% decrease in their score. And next, let's discuss what our steps would be if improvement is demonstrated and if improvement is not demonstrated. So if improvement is demonstrated, the number of patients included in the project can be increased to further evaluate the effectiveness to eventually adopt the new palliative care tool for patients. If improvements are not demonstrated, the team should plan for the next PDSA cycle to refine the process and incorporate any feedback from patients. This could include the timing and frequency of screening tools or adjustments to the structure of the palliative care delivery altogether. Thank you for listening to my quality improvement project. I hope you enjoyed. And here are the references used to create the project. And then one last slide of references here.